3 seconds the PVC disappeared. The initial lesion, then it came back, we gave another lesion, we went up to 45 watts, and then we haven't seen any PVC since then. The pace mapping at that site was 87%, whereas the PVC that we have, the short run of tachycardia that we have from the right side lesion had a concordance of 97%. But the lesion on the right only reduced the frequency of the PVC. They really didn't abolish. They abolished maybe
Pon el sitio
for a few
exitoso.
seconds. So the actual successful site was in the right coronary catheter. You see that.
Pon el eco intracardíaco, Diego.
We would like to see the intracardiac axis, Diego.
Dejen la imagen.
No, leave the carto image on the screen. Diego, could you please put the echo? Let us see the eyes. Entonces vemos
The
aquí.
PVC were gone.
Oh,
Corre a
great.
la
So,
derecha.
so the echogenic imaging that we are seeing below the catheter is the lesion. Is that right?
The blue dot is the successful.
This is the successful place. So, well, so what are your plans to test if you are successful? You are going to wait how long time? Are you using isoproterenol?
Well, he was spontaneous actually. With the isoproterenol, did not get much before when the PVC disappeared, but he was in pretty much by jam, right before we gave the lesion. We haven't seen any PVC for the last. We were close to 30 minutes from the last ablation.
Andrea, I want to take advantage because we are talking about isoproterenol, etc. But your team have described a new protocol to induce PVCs and also to induce PACs on atrial fibrillation. Can you explain us?
With this PVC, many times the isoproterenol suppress them because the sinus rate goes up and suppress the PVC. So usually the best combination is to use isoproterenol low dose with phenylephrine. So you cause bradycardia at the same time with the sympathetic activation. But the isoproterenol alone in many of these PVC actually make the PVC goes away. Recently, we've been trying to use an alternative to isoproterenol for AFib. We use dobutamine, and with dobutamine we saw a similar effect of isoproterenol on the PAC, but also we saw that dobutamine seems to be even more effective than isoproterenol to cause PAC. So that could be, I think we have to look a little more. Dobutamine seems to be a potential pharmacologic challenge for PVC that may be even better than isoproterenol.
Right. So how long time are you using dobutamine? For 10 minutes, 15, 20?
For 10 to 15 minutes. So the same thing to do with isoproterenol.
It's similar protocol than isoproterenol in terms of time.
Yes.
The doses, which doses are you using?
The dose I think is the equivalent of 20 mics of isoproterenol. I think it's 40 mic per minute, but I have to play with different doses. I think the closest is 40 mics per minute of the dobutamine.
Good. So what about phenylephrine?
So phenylephrine, yes. So phenylephrine is actually something that works well because you just need the relative bradycardia to let the PVC go out. So when we use isoproterenol, we use low dose, like 2 or 3 mics with phenylephrine because you want to have some relative bradycardia with some sympathetic, or sometimes we give the isoproterenol, we stop it, we still have the effect and give phenylephrine to lower the rate. But the PVC, you need some relative bradycardia. So the isoproterenol alone, in most of the cases, is not the best diagnostic challenge. Most of the time when you see something is after you stop the isoproterenol, when the right array come down. So if you want to speed up that process, you have to combine it with phenylephrine, so you have the relative bradycardia. And do not use very high dose of isoproterenol for this, because with very high dose, the sinus rate is going to go so fast, it's going to suppress everything.
So in conclusion, we could say that if the patient is on bradycardia, maybe we can use isoproterenol or dobutamine. Dobutamine is similar in terms of induction of PVC, etc., than isoproterenol. But obviously, for a patient with bradycardia, it's not good to use phenylephrine, right? Because phenylephrine induces bradycardia to allow the PVC to come. So it's not logical to use that medication in those cases. So it's a kind of workflow that we can have in mind.
Yeah.
So any more comments, Diego and Andrea?
Yeah, I think it's important, what we were saying before about the pace map. Here we have an example where the pace mapping was better on the right, but in the right ventricle.
Right.
The successful side was in the right coronary cusp, where the pace mapping was worse. So it's a clear example how, in this normal heart PVC, you combine the activation with the mapping, and activation probably is the one that should be more relevant. But you have to sort of look at this information together. There is no one thing that is the best.
Very important point, and we were discussing about it, because if the best pace map was in the right side, in the septal part of the RVOT,
yes,
and the earliest activation was not there, that is suggesting that maybe could be a preferential conduction way, exactly, conduction way, and you are just with your catheter on the exit but not on the origin. So that explains why you can fail even you have a perfect pace mapping.
Yeah.
Do you agree?
Yeah, exactly.
Perfect. Bueno, ¿alguna pregunta del auditorio?
Luis, yo creo que cositas importantes simplemente como para que conozcan el ambiente del procedimiento, cómo se realizó. El procedimiento empezó con una sedación muy bajita con propofol. Realmente cuando el paciente entró en bigeminismo y luego desaparecieron las extrasístoles, se suspendió el propofol y con eso ya el paciente finalmente empezó a hacer más extrasístole. Entonces es muy importante que cuando se utiliza algún tipo de sedación en el procedimiento sea una sedación de muy corta duración. Segundo, el paciente fue anticoagulado formalmente con heparina. Estuvimos
Modulated with heparin, with ACTs between 250 and 300. So with that, we were able to do the procedure. And finally, the applications we did in the right cusp, because we heard a comment about doing coronary arteriography. Basically, we did them based on echo imaging, pointing the tip of the catheter downwards. And in the right cusp, usually we don't have much of a problem with the right coronary artery as it could be with the left. Diego and Andrea, ¿nos pueden describir la cantidad de fuerza de contacto y de potencia que utilizaron en el sitio exitoso? Sí, la primera lesión con supresión inmediata de CVP empezó a 35 y llegamos hasta 40. Con la segunda lesión subimos hasta 45. La fuerza de contacto fue entre 5 y 9. Y creo que el ICE fue de 15. Yo creo que este es un ejemplo en donde tenemos que combinar la información de la fuerza de contacto para titular la potencia. Porque si la fuerza de contacto está por debajo de 15, es muy seguro aumentar hasta 40 vatios o más. Y esto aumenta la probabilidad de tener una mejor lesión. Yeah, we have a question, Diego. Do we need the microphone? Well, this is in real time and it looks like, well, it could be the effect of the isoproterenol effect. Well, it's very important to keep this in mind because we used isoproterenol and dobutamine at very high doses. And obviously, if this is a coronary patient, we will have problems. We had that experience a while ago. A patient with atrial fibrillation and never had expressed chest pain. He always came to the ER with a very quick flutter. He was very well followed by the cardiologist, and we decided to leave a negative perfusion. We gave a challenge. Well, we did all the isolation, but we gave a challenge with isoproterenol, and in the end, he started to develop dynamic changes of the ST segment. And the patient had 3-vessel disease in the end. So we use these doses, but the recommendation is to use them for the right time. We are not going to use half an hour at very high dose dobutamine, only 10 to 15 minutes max. And we have to follow any changes in the ST. When you use dobutamine in the protocol described by Andrea, for instance, those patients that are too hypotensive with ventricular dysfunction, and sometimes it takes hours, that's a signal of the possibility of a coronary lesion that sometimes are missed clinically during the perfusions, etc. Well, Andrea and Diego, congratulations for this excellent case and the discussion. We are going to close your case, and we are going now to continue with another presentation. Thank you very much for giving us so much information. Thank you. We are ready. Well, Fermin did a heroic effort to be able to advance distally in the vein. Yes, we are going to show you what he did. That was a real battle. The idea was to introduce the multipolar catheter, and simultaneously he introduced the Terumo. And with that mechanical support of those two catheters, he was able to advance the Agilis little by little until the Agilis was totally connected or engaging the anterior interventricular vein, and then we were able to advance the ablation catheter. This catheter was positioned more distal to the earlier signals. Maybe we can show it. Yeah, show us an image of how much did you advance with the Agilis. Here it is. Here he placed the ablation catheter, and this is when we decided to measure how early it was. It was about 30, and the pace map was 90 odd. As you can see, the earliest signal was exactly where the perforating was coming out. So the catheter was a bit more distal, but we decided to start from the distal position and little by little to retract the catheter. The impedance was 220 initially. Before it was 180. And then we started to apply radio frequency. First at 20 watts. Fermin suggested that we administer 0.45 saline irrigation instead of 0.9, and he was able to do 2 applications in the anterior interventricular vein. When we moved more proximally, we lost the engagement of the Agilis, and we were not able to re-engage it again. Before that, Fermin and Miguel, one thing we have seen in some cases, even when we get into the perforating arteries, is to dilate the vein by administering normal saline, jet normal saline. Did you try this to reduce the wedging of the catheter and lower the impedance? Did you try something similar? Well, the truth is that we had an impedance that allowed us to do the ablation, so there was no need to do it. But we changed over to the half normal saline. And what happens is that during the application, we had a few phases of irritation with more extrasystole, but now they are back. And now we are with an endocardic approach. Yes, we are going to apply endocardically. If this doesn't work, well, I think that there is one available perforating artery. At this point, Miguel and Fermin are applying with half saline solution in the endocardium. Yes, yes. We haven't changed the irrigation because it would be too complicated from the logistics point of view. We see that they have some difficulty in increasing the contact with the catheter. It's approximately 8 grams. Yes. And you are using a long sheath. This is an SLO of 93 centimeters. It's SL1. SL1 is the sheath, 90 centimeters long. This is a long sheath in order to improve stability and contact for the application. Obviously, the idea is to cause transmurality. This area is potentially too thick, and that determines the duration and the amount of contact. Miguel, could you explain us a bit about the normal saline administration and why it is more efficient? Well, this is a recent contribution by Will Sauer from Denver, who described the size of the lesions, changing the saline solution for irrigation, comparing normal saline versus half normal saline at 0.45, and he described that the lesions were larger when you use half normal saline. So when you use a lower saline solution, there is lower conductance of electricity. So the radio frequency current deflects. It tends to go where there is less impedance. If you create more impedance around the catheter and the surrounding media, the current preferentially deflects. That's the idea. Let me describe a case in our practice. Usually, the solutions to irrigate these catheters are saline solution. Usually that's what we use, normal saline. So in principle, the intent of the saline solution is to increase the impedance around the catheter so that the impedance prevents the loss of frequency and concentrates it in the area where you are applying. That's the principle. We did a case, I don't know whether you saw it in HRS at one of the satellite sessions. This is a case that we solved in a perforating artery where the impedance was extremely high, 200 and something. And we were not able to apply energy and radio frequency, but we were in the right area. So we administered normal saline, we dilated the vein, we worked on the impedance, and with half saline solution, we were able to do more efficient applications and more extended. When we used the normal saline, we were not able to apply it for more than 3 to 5 seconds because with the high impedance, the catheter got warm too quick. With normal saline, we were able to do it. So, yes, Fermin, this is the area where we were applying initially. As you can see on the NAVIX, this is the inguinal region. And we are applying here, and this limited the extrasystole with ablation opposite to the side where we were doing the vein ablation. But it's very curious. You eliminated the extrasystole when you moved more septally. You are more septal now. Could you please show us two images, one right lateral and the other one in LIO, to see the position of the catheter and where the vein was constructed with the wire? Well, we should move to fluoroscopy now. This is the right lateral. I need some fluoroscopy here. Here you have the result. And the left lateral. Yes, one option is that you show it on the 3D map. Yeah, this is the left oblique. Remove the structure of the left ventricle. We just want to see the lesions. Remove the structure of the left ventricle, and we only want to see the lesions. Now this is more septal. Yes, you're further towards the basal perforating. Should we administer isoproterenol? Well, you already administered it in the interventricular. Maybe you have made some changes in the extrasystole. Yeah, the extrasystole. We are having problems because we can't hear and there is a lot of background noise. Fermin, can you fix your microphone, please? Well, my microphone was in the back. That's why you couldn't hear me. Well, let me show you the last lesion. What happened here, Luis? Let us show the electrogram live, the revision electrogram. Show the electrogram on the screen, the revision. No, just a second, Fermin. Can you change the color of the electrogram? Because the red, we can't see the red here. Change it to yellow or white or... Well, this is much better. In the endocardium, it was late. After we did the ablation in the epicardium, we mapped again in the opposite endo, and now it's earlier than the endocardium. I believe that this first potential is not real, but there is something earlier. So this is when we do the application at the endo, and it is opposed to where we did the application. Yes, these are different PVCs. Can you show me? Well, this is the live screen with the extrasystole, which is back so that you can see it. Show the extrasystole, which is back, and show the ablation signal, the very early ablation signal. It's floating around. No, we can't see anything. Why don't you show it to them so that they believe us? No, we do believe you. No, I'm speaking about Miguel. The signal that returned is different. Yes, it can be mechanical, but it's very early. It's too early. Well, any questions from the audience? It's almost 12 and we have a lunch conference. So finally, there was more than 1.5 centimeters distance from the endo. The signal was so early, and that's why they did not start from the endo. Yeah, with more than 1.5 centimeters. I am not sure that they measured. Can you measure the distance between the two lesions? Yes, we have to measure the distance, the closest one. The electrogram showed that it was not early. Yeah, it was noisy. The electrogram showed the initial aspect, which looked to be like far field, low frequency. Yeah, when you worked on the anterior interventricular vein, don't you do coronary angiography? Do you usually do coronary angiography? Well, I will ask this question to Miguel.
Okay, so we thought that we knew that this question would come up, and Fermin doesn't have an answer, so he gives me the question. I I have done since I have been doing ablations in the distal coronary sinus and the anterior interventricular vein. The first times I had an interventional cardiologist by my side, and with an angioplasty catheter for diagnosis in the left main, we injected contrast in the coronary artery for 15 seconds to make sure that we were not burning. After 5 or 6 times, we realized nothing happened, and when we decided to do it here, we are looking at the ST segment, and between the coronary flow, which is so rapid and contributes to cooling of the coronary, is not something that happens regularly. You need to be prepared for that, but we decided here that we were going to take the risk. We agree, Miguel, and in fact, it has been an experience as well. We use catheterization for everything, but now we are not exaggerating because you cannot take minutes and minutes and minutes to try the applications. And so then they switch to the endocardial side, but we also need to bear in mind what the patient has. This patient has an ejection fraction that is low. And there are patients in whom you suspect cardiomyopathy due to extrasystoles despite medical therapy, beta blockers, etc., etc. Yeah, that is very important. So these are decision moments. Obviously, when we see patients with like this, who are not very symptomatic, have a risk, maybe you decide to do catheterization to determine where you are. But what else can we offer the patient? Well, the functional class is low, ejection fraction is low. If you don't do anything for this patient, the patient will will develop or come back with heart failure. So it's striking a balance between the risk and the benefit, and be prepared for anything. In fact, these are cases where at the beginning, we didn't do endocardial because we thought the coronary was closed. Sometimes we did it, but what's the problem? If this is intramural, you don't know if you're going to do well, totally well. But we're going to have to deal with the same thing. If you go epi, you will have the coronary closed. So, okay, an important point, we are going to apply an additional 2 lesions. But we need to describe the importance of the contact force for these types of cases, because you need to have good contact, and the echo is only telling you where you are, but you have to have the information about the catheter. And you mentioned it briefly. I was very focused and I didn't intervene because I didn't want to lose my concentration in that very important step. But the use of the long sheath, a long SL1. Can we see the fluoroscopy so that you can see what I'm talking about? You can see that the SL1 is at the start of the aorta, and this allows to have very good catheter stability in this region. You can see that the catheter doesn't move, and this is important because what you don't want in this region is for the catheter to go upward, which is the biggest risk of damaging the left main when the catheter goes up, because it has little stability. And with that curve, it would go directly into the left coronary artery. And this is a matter not only of outcomes, but also safety of maintaining the catheter in contact and to prevent the contact crossing, because it comes out of the aorta and you have to put it back, and that increases the risk of damaging the valve. A recommendation to refer to the use of this long sheath is that indeed You should never go past the sheath alone because there's going to be damage to the aortic valvular apparatus, and you cannot go with the catheter without deflection, straight and pushing, because that won't work. You need to leave the sheath at this height, at this level in the descending aorta. You advance the catheter, you deflect it in the descending aorta, and you pass it like this to go through the aorta. And once you go through the aorta, you leave the catheter and you advance the sheath very slowly, or else you will cause damage. When you remove the catheter, you need to bear in mind that you need to remove it very gently. If you pull the catheter as a whole, the sheath tends to advance, and if it is alone against the valve, it may cause some damage. Yeah, but the easiest thing is to show it. You just do make the curve in the aorta, and then you advance the whole thing as a unit. The catheter comes with a curve and a pigtail, and you don't push everything because there's a lot of force with the sheath. The catheter goes in, and there you open the catheter with the sheath, and there it is again. Yeah, exactly, that's what I was saying. Okay, are there any questions? We need to close. A question, Roberto? When you were in the coronary sinus, why not do a pericardial puncture to map? That's a very good question, Roberto. I think that obviously, since it's earlier in the coronary sinus, that is a sign that it was earlier towards the outside. Since we didn't have an effect on the coronary sinus, we had to make a decision. I either apply in the endocardium or go epicardial. The problem of going epicardial in this region is that it is usually surrounded by fat, and since it's surrounded by fat, it is very difficult to apply. Not only that, but the fat is there because the coronary arteries are there. But you're right. So what we did was first to apply in the endocardium. If we were successful in the endocardium, since we had already applied in the epicardium indirectly from the vein, then we would stop there. If not, the next consideration would be to go epicardial to see if we could get something more lateral than the interventricular vein, and be fortunate enough to be early without fat and trying to apply from that area. That would have been the next step had we not been successful from the endocardium. But it's important to remember your experience, the experience that shows that in the LV summit, the epicardial approach rarely worked because of that reason. The epicardial approach to this area is usually not useful because the region is a region which is not navigable from the point of view of the use of radio frequency. The only thing where it would be useful is those cases where they are to the left of the anterior descending, where you do it more lateral, and the axis is more straight. You have a greater possibility in AVR and more negativity. And you see it differently, but of course the electro varies in every individual. Yep. Maybe in the afternoon of Fermin, we could go deeper into that electrocardiographic anatomical description of the LV summit. So we're going to finish here. We wish to congratulate you on an excellent case, very illustrative. We all enjoyed it very much here in the audience, and I think that we all learned tons of things. So yes, thank you, Miguel and Fermin. A round of applause for you. And for Carlos. Carlos, yes, yes, of course. All the team. All the team. Okay, thank you. We are going to have our work lunch. It is very important for us to add to this technical and technological information, add also discussions that can promote the growth of our field of electrophysiology, which is